Hey, future respiratory therapist, and all respiratory therapists watching this video. I just got a request come in from me from one of my buddies, Barry. He's a good friend of mine. He was in my wedding, and anytime he sends me a message, I'm quick to respond. Okay, so you're gonna get a little bonus footage here on a late Wednesday evening. I'm gonna go ahead and record it and post it and publish it right now to get it out there. I got more videos coming tomorrow and throughout the weekend, but anytime he sends me a question, I like to respond to him and get his question answered pretty quick. That's just what you do for your friends, right? So late Wednesday evening, and we're going to make a video real quick. So his question is can I do a quick video over a comparison of the Airvo high flow device versus the Salter high flow nasal cannula. Now, if you're not familiar with the Salter high flow nasal cannula, it's basically that green nasal cannula that has a little thicker or a little thicker tubing that allows for flows via nasal cannula up to 15 liters per minute. And then you have to use that non-disposable bubble humidifier because the disposable bubble humidifier won't tolerate flows greater than 6 liters per minute. They'll tolerate a little bit higher than 6 liters per minute. For the most part, you can't take them up to 12 or 14 or 15 liters per minute because the high pressure alarm will go off. So, and then second part of the question is why would you use one from the other in the hospital setting? So we're going to break this down real quick. Now I did a video over Airvo not too long ago, so I'm going to quickly recap that. Then we're going to give you the highlights of the Salter high flow nasal cannula, and then we're just going to lay it out for you. And you tell me which one you think is better and why you would choose one over the other. So we already kind of mentioned it. The Salter high flow nasal cannula allows for O2 up to 15 liters per minute. One of the things they claim is that it's more comfortable. Comfort is one of their claims to fame. So in other words, you could use this device at 10 or 12 or 8 or 15 liters per minute, which is the max, instead of using some sort of mask. So you wouldn't have to use a simple mask if for some reason you're still using simple mask, or a Venturi mask, or even a non-rebreather mask if for some reason you're still using a non-rebreather mask. So O2 up to 15 liters per minute, and it provides comfort. Okay. Now, on the Airvo side of things, we know that the Airvo offers an increased ability to offer higher levels of O2. So this is 21 to 100% when you're talking about FiO2s, and it generates some level of PEEP. Okay, so when you're talking about PEEP and you're talking about Airvo, you know you set a flow, and the flows coming from the Airvo device, you can set it anywhere from, I'm not sure what the lowest setting is, but I know you can go anywhere from about 30 all the way up to a max of 60 liters per minute. So you can give 60 liters per minute of 21% oxygen. You can set these independently from one another. So that in itself is an advantage because you can treat and you can maximize, let's say your patient who's flow hungry but doesn't necessarily need higher FiO2s, you can give them higher flows to satisfy their flow starvation, but at a lower FiO2. So you can give 60 liters per minute at an FiO2 of 30%. So that right there suffices your 2 points on how we oxygenate our patient. Okay, now I'm gonna go back into this in just a second. The second thing that we offer is decreased dead space. The third thing is increased heat and humidity. And then the fourth thing is comfort. They talk about comfort more so in compliance. So you have a patient who won't tolerate, say, a BiPAP mask. Airvo claims, and is actually visible, you can actually see this, where a patient isn't compliant with a BiPAP, you can oftentimes replace that BiPAP with an Airvo device, generate PEEP, offer higher flows, and even though it doesn't make sense in our respiratory therapy minds, because you go BiPAP offers inspiratory pressure support. You got EPAP and IPAP and that inspiratory pressure. Airvo doesn't do that. You're right, it doesn't. But what you have to understand is that Airvo, through decreasing dead space, equals increasing alveolar tidal volume. When you increase alveolar tidal volume, you actually aid in the removal of CO2. And so yeah, we're not removing CO2 by generating larger tidal volumes, per se, how we say larger tidal volume. We can look at the screen and say, oh, okay, we increased IPAP, and so tidal volume went from 300 to 500. So obviously we're increasing minute ventilation. But when we say that, we're not talking about alveolar tidal volume or alveolar minute ventilation. We're just talking about, in general, tidal volume and minute ventilation. But we fail to sometimes realize that a portion of that tidal volume is lost in anatomical dead space, and a portion of that tidal volume, especially when you're talking about BiPAP, is lost in the mask itself with mechanical dead space. So with Airvo, the Airvo high flow nasal cannula, by simply decreasing anatomical dead space, by the washing out of anatomical dead space from the high flows, what we see is without offering any inspiratory support, we still are able to increase the effectiveness of the tidal volume by increasing the alveolar tidal volume, by, I'm going to say, increasing the purity of the inhaled gas. So you don't get that initial rebreathing of anatomical dead space gas. So increasing alveolar tidal volume, increasing the alveolar minute ventilation, and these patients seem to do better. And they seem to do well with it. And if you have any experience with this, you've probably seen it, and you probably go, wow, like, I didn't get this until I really started working with it. And then it starts making sense, and you go, okay, I get this. So that's when we talk about comfort, we're talking here. You don't have to put a mask on a face. You don't have to put some type BiPAP. You don't have to put a venturi mask, a non-rebreather. The same as what they're saying here, okay? So from this perspective, comfort versus comfort, I think it's a wash. I don't think one is more comfortable than the other, okay? The other thing that the Salter high flow nasal cannula states is that it's quieter, and I'm going to talk about that in just a second, okay? So that's kind of the breakdown of the devices. Now, when you say which device would you choose in the hospital setting for different scenarios, different patients, I can tell you that this video now goes from just stating the facts to kind of more of an opinionated video, to where I'm just going to give you more thoughts on what I think when I'm taking care of patients. And where my mind goes with this is that, yeah, I can give up to 15 liters per minute, but in regards to FiO2, what does that equate to? What is that? If I have a patient on a 12-liter Salter high flow nasal cannula, I know my patient has an increased oxygen demand. I know they need more oxygen to sustain an adequate level of oxygenation. But I don't like to find myself in a situation to where I'm just giving some obscure flow that I can't equate to an FiO2. So even though you can give up to 15 liters per minute, and they call this a high flow nasal cannula, what they're saying is that you can give higher flows than a normal nasal cannula. But it's still not a high flow device. You're still not delivering a set fixed FiO2, and you're still not necessarily meeting or exceeding the inspiratory flow demand needs of your patient. So it's still a low flow device in which you don't know how much FiO2 you're given. So for me, I'm insanely obsessed with my PF ratios. So for me, a patient on a Salter high flow nasal cannula of 12 liters per minute is frustrating because I can't adequately assess my effectiveness of oxygenation, because your FiO2 is some obscure thought that you can't put a number to. You don't know what it is. It's just 12 liters per minute. Okay, but what is that delivering? What's the FiO2 being delivered? Don't know. To where with Airvo, I know exactly what my FiO2 being delivered is. Why? Because Airvo is truly a high flow device. It meets and exceeds the inspiratory demand of our flow through the flow setting, and it delivers a fixed FiO2. So that right there tells me that when I get a PaO2 back of 65 and I'm on 12 liters over here, but I'm on 50% over here, I can adequately assess my effectiveness of ventilation. Now the other thing is if the patient needs more than a regular nasal cannula, more than 6 liters per minute, which you can give through a regular nasal cannula, then we would all probably assume and could agree that this patient has an increased oxygenation requirement. If that's the case, then I would prefer a device that also generates some level of PEEP. Now this Airvo device is able to be personalized to the patient. So in regards to, as opposed to the Salter, to where it's one device, it's one cannula, the prongs are the size of the prongs, and you put it on the flow no matter what. The flow is the flow. You can't adjust FiO2 different from flow rate. So FiO2 is directly proportional to flow. But take somebody with really large nares and put them on a high flow Salter. That delivered FiO2 is going to be varied versus somebody with really small nares that has more obstruction of the nares in regard to the Salter high flow nasal cannula. To where with the Airvo, I can actually choose between small, medium, and large cannula size, so I can approximate to get about 50% obstruction of the nares. And when I achieve that, that's when I know that I'm also going to generate about 1 centimeter of water pressure for every 10 liters of flow I'm delivering through the Airvo device. So if I'm delivering somebody 40 liters per minute, I'm generating approximately 4 centimeters of water pressure of PEEP. Doesn't sound like much, but if you have a patient with an increased oxygen demand, wouldn't it be nice to be able to give them a little bit of PEEP? Obviously, there's some type of probably a shunt present, and we all know that with shunts, positive pressure via PEEP and other mechanisms help to improve that oxygenation process in the presence of that shunt. So obviously, I'm going to lean towards Airvo in that case anytime I'm thinking about a patient who needs something more than just a regular cannula. Look, I'll be honest with you guys. Like, I'm leaning towards Airvo anytime my patient needs more than a nasal cannula. I'm very rarely grabbing VentiMask anymore. I'm hardly ever grabbing non-rebreathers. Like, they just don't exist in my world anymore. If a patient needs a non-rebreather, I'm grabbing an Airvo. Why? Because of everything I already listed over here. Very effective in oxygenating via FiO2 and PEEP, increasing alveolar tidal volume, which, let's say you put them on 10 liter cannula over here, and you put them on a flow of 40 and 40% over here. You may be actually delivering a higher FiO2 at 10 liters per minute with the Salter, but they still may have an increased work of breathing because, one, you're not meeting their flow demands, and two, you're not effectively altering alveolar tidal volume, which is but through the washing out of the dead space. And so you get this patient who's on 10 liter high flow Salter nasal cannula and they're still tachycardic and still tachypnic, versus putting that patient on something that you know exactly what you're delivering that benefits with the washout of dead space, which increases alveolar tidal volume, which increases alveolar minute ventilation, which aids in the removal of CO2. You're going to see that patient probably have a more satisfying experience and a decreasing of cardiopulmonary workload, where you have a reduction in heart rate and a reduction in respiratory rate, because this device, in my opinion, oxygenates so effectively and aids in ventilation through the decreasing of dead space. Now, when it comes to the increased heat and humidity, you got to give bonus points to the Airvo here also, because we know that when you maximize optimize heat and optimize humidity, then you optimize mucociliary transport. So if you have any problems and any oxygenation issues that are related to secretion clearance, then Airvo by far is going to overcome and address that and aid in that secretion clearance mechanism. To where over here you're delivering, a high flow of gas through a nasal cannula through a bubble humidifier, not heated, just a standard bubble humidifier. So the humidification may be there, But studies have shown that adequate heat is, as opposed to the inadequacy of heat, to where just from a bubble humidifier, room air, cool bubble humidifier, isn't as effective as adequate heat and adequate humidification. So you got to give bonus points to the Airvo through the maximizing of the mucociliary transport. We already said that comfort is the same because they're both nasal cannulas. Some might say that the flow coming through the Airvo is a little much. Some might say that the flow coming through the high flow nasal cannula is a little much. So I don't, that's just a patient difference. Now, I will tell you that when you look at the Salter high flow nasal cannula marketing material, when they compare themselves to high flow nasal cannulas, they call them heated high flow nasal cannulas. They're talking about Airvo. The only thing they can say is that they're quieter. If you've ever worked with an Airvo device, you know it's not terribly loud. If you've ever worked with a Salter high flow nasal cannula and you run 10, 12, 14, 15 liters per minute through a bubble humidifier, you know that bubbling of that bubble humidifier actually generates more noise than the actual Airvo device set up properly. So, the last thing I have to say is, in today's world of respiratory therapy, in my opinion, the Salter high flow nasal cannula is just an alteration of an old school device, the regular nasal cannula. Somebody said, why don't we make one just a little bigger and allow it to deliver up to 15 instead of maxing it out at 6? Like, where did that magic number come from? Who said you can't put a cannula on 7, right? Old school theory, right? 6 is the max. Okay, 6 is the max. So now let's make one that can go to 15. Fantastic. But at the end of the day, the fact that I cannot pinpoint and know exactly what my FiO2 is tells me that I do not know how much oxygen I am delivering to my patient. It's as simple as that. And when I do not know exactly how much FiO2 is being received by my patient, then I do not know the exact amount of drug that I'm delivering to my patient. Do not forget that oxygen is a drug. This would be like giving morphine to a patient and not knowing how much you're giving, or any other drug to a patient and not know exactly the dosage that you're giving. You may know you gave 3 mLs or 5 mLs or 12 mLs, but do you know the dosage that you actually gave? No, I just gave 12 mLs. Well, what's the dosage? I don't know. I just gave 12 mLs. That doesn't sound like good medicine, does it? That doesn't sound like good practice. And so I think of the same thing when I think about these devices. As a matter of fact, I think of that when I think about any oxygen device that I cannot pinpoint my FiO2 on. Now, I'm not saying I never use a nasal cannula. I'm not saying I never use a simple mask, because they're in use. And yes, there are times that fit those bills. Okay, there are patients that say this is the right device for them. But when I have a sick patient and I have to decide how to adequately oxygenate this patient, this Airvo device meets every one of my needs for that patient from a respiratory therapy standpoint. I like the precision of it, and I like the way that it gives me the ability to get on top of the problem instead of chasing the problem. This is referred to as the reduction of escalation of care, as opposed to the chasing of escalation of care. We've all had that patient to where we have them on a nasal cannula. At the beginning of the shift, they're on 2 liters. At lunch, they're on 4 liters. At 3 in the afternoon, they're on 8 liters. Now we're on a high flow Salter and they're on 10 liters and they're on 12. What are we doing? Are you just going to keep increasing the FiO2, the flow? You don't even know the FiO2. Just going to keep increasing the flow until they bind in the tracheal tube? Or are we going to get ahead of the curve, effectively treat the signs and symptoms with a device that provides so many benefits, as opposed to a device that's just enhanced from its original style? It's like it's like the evolution of, I don't know, the 8-track to MP3. This is what this acts like to me. It's just a little better. But it still essentially does the same thing. You still don't know your FiO2 you're delivering. You still don't know exactly what your patient's getting. It's still a low-flow device. Why use a low-flow device at 15 liters per minute on somebody who really needs 15 liters per minute? That doesn't make sense to me. Now, having said that, I hope this video helps. Barry, appreciate you sending me the text, man. And anytime you got a question, I'll get it out to you as soon as possible, okay? I appreciate all you guys for watching. Please leave me your comments, your concerns, your statements. Tell me your experience with the Salter high flow nasal cannula. Tell me your experience with the Airvos. Tell me which one you preferred. Tell me what patients seem to do better with which. And come at me. Let me know. There may be something here I'm missing in this whole Salter high flow nasal cannula. I just know personally, I've never picked it up and said, I think this is the right device for this patient. I've always gone with basic, minimal needs. Anything greater than that, I'm grabbing this bad boy right here. Okay? Hope everybody has a great day and is enjoying their life as learning to become a respiratory therapist or currently working as a respiratory therapist.